A very good morning to everyone, and thank you for the invitation and to present my work. I'll be talking about innovators versus biosimilars. So I do not have any financial interest in any of the molecules which I'm going to be talking about, and the data which I am presenting is either from the Government of India available on websites or it has been taken from the OEMs themselves. So what is our understanding of a biosimilar? So biosimilar is a drug which has been made in a slightly different way compared to the parent molecule and may have different substances in its constitution. But it is supposed to work just as well as the parent molecule for the drug to be given certification. So that brings us to the question that most of the biosimilars that we see are either equally efficacious to the parent molecule or sometimes they are bio-betters in turn that their efficacy is higher. The thought of biosimilar being less efficacious is not scientifically correct because unless the drug has equal efficacy will not get an approval. The issue always came with standardization and quality assurance. And we have the story of Razumab as a classical case study where between 2015 to 2018 they had 4 reported events of adverse drug reactions. Certain batches were recalled, but 2018 onward the drug has found a great percolation in our retinal practice, and today it is the leading anti-VEGF in India. So we know today that we want to know what is the spectrum of biosimilars which are available with us, how they are performing when compared to reference molecules, and how they perform when compared to off-label drug usage, that is bevacizumab, and we should talk about their comparison to newer anti-VEGFs. The topic of my talk will restrict to the first and the second point today. So talking about ranibizumab, we have a gamut of drugs which are available to us. The principal one available in market for a long time is Razumab from Intas. At Army Hospital RR, we have a pretty long experience with Razumab usage. Next is Eccentrix, then Vizumab from Reliance Life Sciences, Osiva from Sun Pharmaceuticals, Ranizurel, Rani-Eyes, and all these manufacturers which have gotten approval outside our country and may enter our country sooner or later. So we have sufficient safety data and efficacy data of Razumab, and just to highlight one simple case, this case of diabetic macular edema, first dose, second dose, and by third dose, you find that the anatomy of the macula is just as good as it being treated with Eccentrix. So we have an accepted data on 4-week durability of these drugs. 3 loading doses are advised, and adverse reactions are similar to Eccentrix, not more than that, and the drug is fairly cheaper, whether we talk about Razumab or we talk about Osiva. With Osiva, we do not have a very long experience. It has been recently introduced, but the early reports are quite promising. We have heard the work of Dr. Jayashet, and we believe that this drug is likely to do very well in future. Ranizurel again has a similar success story, and how these biosimilars changed our practice is the interesting thing to know. At RR, our consumption is about 3,000 doses a year, and when you look at the data of 2018 till date, when we look at the total number of injections which were given, the chunk of injections were ranibizumab, and out of that large chunk, Eccentric used to enjoy predominance till about 2020. And in 2021 onward, we can see that there has been a surge in the usage of Razumab, and in future we believe other biosimilars too. Now we talk about another anti-VEGF, because my topic has been to compare the biosimilars with the innovator molecules. So we have a new innovator molecule called Brolizumab and Aflibercept, which has been around for about 10 years. So when we talk about Aflibercept, the biosimilar from Intas is likely to enter the market soon, and we are all eagerly awaiting the arrival of that drug. So again, the change in our practice I had not shown you earlier that how the ranibizumab chunk was changed with the other longer acting anti-VEGFs. So from 2020 onward, we started using more of aflibercept and brolucimab. I'll come to the reasons why. And the predominance of brolucimab in our practice has increased. So the take-home messages till now are that the market share of ranibizumab is reducing. So does the total number of injection. The newer anti-VEGFs do give better durability. But we have our reservations with reports of IOIs with brolucimab, also with faricimab, which is going to be introduced. Even before its introduction, the reports of IOIs have started pouring in. So to tell you about the efficacy of brolucimab, we did a small study in diabetic macular edema using a reduced dosage, that is 3.6 milligram dose. This compares to about 0.03 ml in your vial. We had two subgroups, equally matched in age and sex, and you look at this box and whisker plot, the change in visual acuity from first week till about 28 week, and this is the 6 milligram chart, this is the 3.6 milligram chart. They both look amazingly similar, and we talk about the best corrected visual acuity and the central macular thickness reduction. They're almost identical in both the subgroups. So the 3.6 milligram dose, that is almost half the dosage of brolucimab, is working equally well. Why we did this, I'll be talking about it soon. The number of injections in two groups were also far lesser as compared to our experience with ranibizumab. Serious IOIs did occur in both the groups, could be managed with local peribulbar steroids, and we did not have to shift any of the patient to oral steroids. We have had a very long experience with drug, this particular one, brolucimab, and we published our data of neovascular AMD way back in 2022, where we brought out that the inter-injection interval with brolucimab ranged at a mean of about 14.2 week compared to 6.8 week with aflibercept. So this drug definitely had a longer durability. We have extended the indications of brolucimab in our practice, and as I told, we are still awaiting the arrival of faricimab. So this brings us to the point that biosimilars, yes, they have very good efficacy as compared to ranibizumab, that is eccentric, the parent molecule, but the longer durability is definitely there with the new parent molecules, the innovator molecules. But what needs to be answered is that why then we are not adopting biosimilars across the country? This question needs further look into the pharmacoeconomics of anti-VEGF. I'll be cutting short on this particular part. The treatment cost, as we all understand, they not only involve the direct medical cost of the injection. There are indirect medical costs, the cost to the hospital in providing the OT, in providing the staff which is going to give the injection, and the loss of man-work hours which occur especially in our country, where an elderly gentleman is always accompanied by one healthy person of the family whose productivity is lost. The disease burden as of today, when we look at neovascular AMD alone, is close to about 6 lakh patients requiring anti-VEGF injections per year. When we look at the sale figures till about 2022, we see that there was just a sale of 1,14,000 units of anti-VEGFs, and the market share of 322 CR of anti-VEGF usage does not fill in this gap of about 4.5 lakh unmet need patients. The sale of ranibizumab has been steadily increasing. This solidifies our argument that biosimilars are doing well. But the question that remains is that these 6 lakh patients will require close to about 18 lakh doses per year, and the current approved sales are just 3,18,000. So what is happening to all those unmet need patients? Either they are being treated with off-label drugs like bevacizumab. I am not against bevacizumab, it's a wonderful drug, but the off-label nature of this drug makes the administrator, the doctor, prone to medico-legal hassles in future. So the way forward is more penetration of biosimilars which can have reduced dosage, one. Second is using longer durability drugs which reduce the total number of injections which are required. And our approach at halving the dose and halving the cost required to treat a patient may go a long way in at least reducing the burden of DME patients requiring this drug. Thank you so much.
I have one question. How was it 3.6, the half dose? How did you come to that?
Okay, so the approved indication for ranibizumab for diabetic macular edema as per US FDA was 0.3 milligram and 0.5 milligram for neovascular AMD. When we had approval of brolucizumab, it was for 6 milligram for neovascular AMD first. So when you go with the fractionation, it is 3.6 milligram. Why they had chosen 0.3 milligram to be tested in their patient was also for one reason, because in the syringe, you can only fractionate it to 0.03 ml. There is no demarcation line between 0.02 and 0.03 ml. So when you go to 0.03 ml, you are left with, if you are taking ranibizumab, 0.3 milligram. If you are taking brolucizumab, 3.6 milligram. That is the logic behind this dosage.
So you didn't do an exact half though?
No, we did not do an exact half dose. That is what I brought out. It is almost a half dose, but it is 3.6 milligram, because if someone says they did 3 milligram, I'll be surprised how they quantified it.
Got it at 50%, okay.
Hello, sir.
Yes, sir.
Do you advocate biosimilar be used in ROP, or do you have any evidence or data it being used in ROP?
Yes, sir. And in fact, on that account, there is a study from RP Center which talks about use of Razumab in ROP. And we are also using Razumab at our center in ROP cases without any IOI seen till date.
Okay.
So, any thoughts, sir?
I'm not sure as to why the 3.6 was equivalent to 6 milligram. I'm not sure as to why. Because the whole concept was that we give more dosage so that it lasts longer, but then the duration of the efficacy as well as the number of injections seem to be the same. That's something which was surprising. In fact, right now, actually, I go the other way around. Aflibercept, I usually give 4 milligrams now, because that's how much you get in the vial. So I do give 4 milligrams. And I can't say that it lasts longer. Probably I'm giving the best, because their studies have come up with 8 milligrams.
8 milligram, yes.
So, but we don't have an 8 milligram, but what is there in the vial, about 0.15 is there. So we are able to comfortably give about 0.1. So that's what I do. I'm surprised with the other way around results of this.
So routinely all patients receiving aflibercept, you're giving almost the...
Yes, but only thing is you have to do a paracentesis, because
yes,
the
because the
IOP
volume is high.
So I do now, after last nearly about a year, I have been giving 4 milligram, though we have not published the results. But then just on a gross, when we looked at the duration, it seemed to be almost the same, probably another 2 weeks extra we get.
6 weeks. Okay.
So we also tried actually 100 patients of aflibercept, in fact we gave 5. So, but honestly, those 100 patients did not show any additional benefit to the 3 milligram.
So do you think 8 milligram is going to make a difference? I think the reasoning is something else.
Probably the reasoning is the same. The higher, as Sir said, the higher
molar dose.
The molar concentration. That's the same thing that is happening with brolucizumab. Probably we are giving much more that is actually required to create a response, but we are giving the extra dose for the duration.
So I was hoping that with the 3.6 IUI maybe less, much less.
Sir, the data, the number of patients that were recruited were very small. As I told you that these patients, 44 and 42 patients receiving 120 odd injections each, having one IOI in each group, we cannot really comment on the incidence of IOIs because of the different dosages. By far, we have completed 1,770 injections at our place. We have had 4 serious IOIs. We have not lost a single eye. So that is what we can share in the long term. So there is nothing to be, I should say, afraid of brolucizumab as a molecule. It's a wonderful molecule, but one has to be careful and the patient has to be counseled before giving the molecule that we are giving you a stronger drug, but please expect a stronger reaction as and when it happens.
So futuristic, you showed the wonderful graphs that biosimilars increasing,
yes, sir.
The innovators decreasing,
yes,
long duration molecules increasing.
Yes, sir.
So ultimately, I foresee another this thing that after some time, both this, biosimilars of ranibizumab as well as innovators, they will reduce much, and then duration molecules will go higher up.
Absolutely, sir. Absolutely. And once the biosimilar of aflibercept comes in, then the final touch will come when the innovator molecules may disappear from our shelves. I'm not claiming anything, but that may happen. But brolucizumab and faricimab, for them to stay in the market for a long time, we'll have to see the long-term result. With brolucizumab, I'm quite sure it will stay for a long time.